Thank you. Chair recognizes the gentleman from Tennessee, Mr. Green.
Thank you, Mr. Chairman, and thank you to all of you guys for being here today. It's greatly appreciated your involvement in this process. Very quick, my questions, I'm going to try it because I got lots of them. Mortality rate, it appears to be about 3% in China. Outside of China, it appears to be about 0.7% is what I saw in a JAMA article that was just published. What are your thoughts about that delta? The Journal of the American Medical Association seemed to imply that it was attributable to China's smoking rate, other reasons, but why is their mortality 3% and outside of China it's 0.7%? In South Korea it was 0.12%. So your thoughts on that?
It's too soon to say because things are changing rapidly in other countries and they don't have as much data being published as there is in China. One of the factors in Wuhan does seem to be the surge in hospitals, and it does seem like some of the people who could have used ventilators did not get them because they ran out of ventilators. So that's one possibility. There is a possibility that there's some underlying health conditions or pollution or smoking or something else that will fall out in analysis, but I don't think we have strong understanding of that yet.
Okay.
And it also, the other thing is important is that there is a time lag from when countries discover cases and begin to see them and the time that people begin to die from this illness, sometimes as long as 2 weeks. So if it's a country just beginning to report illnesses and deaths, it's really two weeks later when we see a real better sense of deaths.
Sure, that makes sense. I just know the N is like well over 3,000 now for outside the country, so you would think that that would give you some degree of confidence, but and there's such a huge delta between 3% and 0.7%. This obviously, based on the way it's hitting those who have comorbidities and the elderly, is probably a very good virus to tackle with a vaccine. But I'm also aware that this attacks the lung tissue directly, so that makes it concerning. We need to be very safe as we develop this vaccine. Sort of in the interim time frame, there's remdesivir and the monoclonal antibodies, and I just wondered if anyone could comment first on remdesivir and some of the other antivirals that were developed for Ebola and their usefulness. I know there's a test in Nebraska. And then on monoclonal antibodies, because of the ability to blunt the lung tissue's damage with monoclonal antibodies, and they can be spun up so much more quickly than a vaccine.
So I'll start with the antiviral question. Yeah, I'm hopeful. I really want these antivirals to work. But at the same time, you got to think about what we've learned about respiratory infections and antivirals so far. We have several antivirals for influenza, and they might mitigate a little bit, but they're not curative. So we need to not overpromise on what we might ultimately see. So hope for the best, but I won't be surprised if we're a little bit disappointed. In terms of monoclonals, again, almost every outbreak that I've dealt with, the first thing people do is use serum from recovered people and try to see if it's helpful. So that's the intellectual background for using monoclonals. And they may very well be useful, but on this kind of situation where the severe pulmonary disease is caused by a cytokine storm, which basically means broad inflammation that's very tissue damaging, you have to test the safety of the monoclonals very carefully, because what you wouldn't want to have happen is put an antibody in there and actually make that cytokine storm worse.
Sure.
It's got to be tested. I hope again, but I agree with you, these approaches to treatment can happen much faster than a vaccine, so they are definitely a high priority.
Well, thank you for that. One of the things that concerns me, there's lots of legislation in Congress about price fixing for pharmaceuticals, and I know Merck is one of those companies that would be hurt by that. My concern is particularly those smaller companies, the biomed companies that, when they have an idea, they have to go get capital in order to advance that idea. They're not going to get capital if we price fix. So I wondered if someone, particularly, ma'am, you, because you are from the industry, could comment about how damaging price fixing might be on some of the innovation that's out there that could address this issue.
Yeah, first of all, as I said earlier, 40 biotech companies have stepped up on coronavirus, but understandably, the entrepreneurs are very apprehensive about what this will mean to investors, and price fixing is the thing that investors hate the most, and they made that very clear when the subject came up on another topic. I live it in the world of antimicrobial resistance because we don't have a market for antibiotics. There is no reimbursement appropriate to the danger of multi-drug resistant infections. And last year we saw 3 companies that had new antibiotics that failed and went out of business because their investors pulled back. So it's a real issue, and we need to keep our biotech industry alive.
Thank you for sharing that. Thank you, Mr. Chairman. I yield.
Thank you.